All right. Alice, can you hear me?
Yeah, loud and clear.
Okay. I think we will make a start as we have a lot to run through. Thank you, everyone, for attending a special sort of a conjoint meeting of NCIC ID teams at Peter Mac, Royal Melbourne, and within the precinct. Today we have a special number of presentations involving active TB as well as conundrums with concurrent active leukemia in the setting of AML and ALL. Eddie Cliff is going to give us an overview of venetoclax. Emily, expert in Haematology Pharmacy, will talk about some of these really difficult drug interactions, and hopefully we'll leave a bit of time for some multidisciplinary discussion at the end of what we do. So also just want to acknowledge that it was actually World TB Day last week, so this is very well timed, and we have a wonderful sort of big audience today with attendees from Canada, around the states of Australia, Tasmania. We have people coming in from Singapore and all over the country. So we are recording as well, so happy to share at a later stage for colleagues who may not be able to attend at this time. So without further ado, I will get Alice to start.
Great, thanks, Michelle. Hi, my name's Alice. I am the ID registrar over at Peter Mac this year. I can see quite a number of familiar as well as new names on the list, so it's nice to see you all. I'll just get the right screen up. Hopefully you can see that okay?
Yeah.
Perfect. I'll whiz through these two cases in the interest of time, but I'm here to present essentially two instances of relapsed AML with patients who are also grappling with active TB infection. So the first case is of Mr. TN, who's a 66-year-old gentleman with pulmonary TB, and this is in the setting of an allograft for a relapsed AML. Regarding his AML history in a bit more detail, he was initially diagnosed some 20 years ago whilst overseas, where he was treated with chemo and then underwent auto graft at that time. But unfortunately, in the last couple of years, developed therapy-related MDS, which is confirmed on bone marrow biopsy, with the cytogenetics and further sort of workup is listed, which then warranted further induction chemo with 6 cycles of venetoclax and azacitidine, which was completed in April of last year, and thankfully achieved complete remission after his initial cycle. It is worth mentioning that in that initial induction phase, he did have some complications with fevers and some pulmonary infiltrates that were quite extensively worked up with a bronch, which thankfully was culture negative and as well as being negative for fungal and AFBs at that time. And then it was in May of last year that he ended up proceeding to a matched unrelated donor transplant on the 18th of May. Just by way of background, some of his social history, he is originally from Vietnam and migrated to Australia in 2019. And currently lives at home with his wife and 2 daughters, all of whom are in good health. And he's otherwise got quite bland epidemiology, maintains quite good level of function. So sort of reorienting to his sort of allograft assessment, he had the usual baseline serological workup as listed here, but notably had a positive quantiferon, which was of note mostly because of a negative quantiferon back in 2022. So you can see his original result there with an acceptable mitogen control. And then the repeat quantiferon, which is a low positive. It was at this time he was seen helpfully by the VIDS team for, I guess, some impression of that quantiferon and what to make of it. And not unexpectedly, his pre-test probability of TB exposure was fairly high based on his epi, but thought that his cutoff being quite low, that reactivation risk at that time was not necessarily very high, and certainly worth considering latent TB treatment, but for ongoing discussion pending his overall progress. So in terms of his timeline, we start with his allograft, as mentioned in May of last year, with some early complications of polymicrobial bacteremia, C. diff, BK cystitis, etc. But thankfully, he recovered from all those issues fairly well and ended up engrafting at day 21 and was discharged home shortly after that. And it was a good 2.5 months later that unfortunately he was readmitted with a respiratory illness, and a bone marrow biopsy at that time unfortunately confirmed relapse of his disease despite his recent allograft. Regarding his respiratory illness at that time, he was treated empirically, and we didn't really have much in the way of microbiological diagnosis, but he seemed to make a reasonable improvement. Sort of during this admission that he had a CT chest, and I'll sort of move through this manually. But essentially, you can probably see that there are some patchy ground glass changes throughout both lung fields, predominantly in the lower lobes. You can sort of see some of that as we sort of scroll through there. And it is worth sort of highlighting that at that point, he didn't have any obvious features of pulmonary TB. Oh no, sorry, let me just try and get my PowerPoint to catch up. Again. So not long after that admission, he has yet another, this time with RSV and rhinovirus infection, as well as being treated empirically for superimposed bacterial infection. And it was a very brief hospital stay. And over the course of these admissions, there is some discussion about what his trial options will be given his relapsed disease after his allograft. In that time, he's agreed to for isavuconazole for ongoing fungal prophylaxis. He doesn't last very long at home before being readmitted once more, this time with neutropenic fevers and EBV reactivation, getting broad empiric antibiotic cover in the intervening period, and has yet another interval CT chest, which shows more or less stable changes of those ground glass opacities. And during that same time has a PET CT for further workup. You can see here his PET images, which should scroll through on their own, but we'll pause at notable bits. But essentially, he has quite marked mediastinal lymphadenopathy on that PET, which raises suspicion of PTLD. And I don't think this is going to work, unfortunately, sorry. But it's worth mentioning that there was some low-grade uptake within both lobes of the lung, and again, reflecting those ground glass opacities we saw earlier. And these were favoured to be inflammatory. Sorry about this.
Oh, it doesn't like your media, does it?
No. That's right. There won't be any more after this one. Again, during this admission, he actually gets some sputum sent off, and it's at this point that we diagnose him with TB on both smear positive but also PCR positive, without an RPOB mutation being detected. And subsequent to this, he's referred on for bronchoscopy and EBUS, which unfortunately there ended up being some logistic delays, but come across that shortly. So around the same time, he ends up being commenced on weekly rituximab for a presumptive diagnosis of PTLD. Again, this is prior to EBUS investigation. And there's actually continuous discussion amongst the relevant teams about when and how best to start TB therapy. And it was on the 3rd of October, so a good couple of weeks into his admission, that a consensus was made to start HRZE. And thankfully, in that early phase, he tolerates his medications quite well and doesn't have much in the way of side effects. It's about a week after his initiation of TB treatment that he undergoes EBUS with histopath that doesn't demonstrate any malignant cells, nor does it reflect any infection on histopath, but We know, of course, that the TB is already being treated. And at this point, he's converted to being smear negative. And then a week after that, he's discharged home with plans for ongoing close follow-up. That said, the problem remains at this point that he will eventually need trial therapy for his AML, and he's not eligible for it while he has active infection. And even then salvage, as attempts at salvage venetoclax may be compounded or made much more challenging with his TB therapy. So yeah, as mentioned, his dilemma is that even in this outpatient setting, he has this progressive cytopenias requiring transfusions, and of course the relapsed AML with ongoing progression there, requiring venetoclax and AZA to bridge him to trial therapy. And of course, the concerns about suboptimal responses to that treatment while he's on his TB medications. Some of the medications and alternatives that were discussed at the time included a bedaquiline-based regimen, which at that point in time is quite difficult to access, as well as the alternative of substituting his rifamycin for 2 other active drugs, moxi and linezolid being the main contenders. But of course, balancing the fact of longer treatment likely to be needed, the toxicities of linezolid, but also difficulty in this fairly evidence-free zone. So again, in terms of his progress, he gets seen in the TB clinic over at RMH, at which point he's changed over from rifabutin to moxifloxacin, and unfortunately has an admission to ICU not long thereafter with an unrelated issue around, well, what was thought to be unrelated, but pulmonary hemorrhage, which he couldn't undergo bronchoscopy for further investigation of, was managed empirically with tranexamic acids, high-dose steroids for what was presumed to be sort of the inflammatory sequelae of his treated TB. And then he eventually proceeds during that admission to venetoclax and azacitidine. And at his 2-month treatment mark for his TB, he has his pyrazinamide and ethambutol ceased. And thankfully makes it home in one piece. So at this point, with his moxifloxacin and isoniazid dual therapy, he's planned for 12 months of treatment. So as mentioned, that longer treatment course. So as it stands, this is a summary of his current medications. He did get bridged to a menin inhibitor trial, as well as the venetoclax, as previously mentioned, and some weaning steroid. As far as antimicrobials go, you can see the isoniazid and moxi, as mentioned, as well as some of his prophylaxis in the background and some other supplemental medications as well. And so he seems, by all accounts at the moment, to be managing well in his trial medication for the last 2 months, remains on his TB therapy with excellent adherence, and continues to follow up both with PMCC and RMHID. And just for completeness, this was his finalised culture at the 2-month mark. You can see that he was smear positive here, and he grew Mycobacterium tuberculosis on his culture as well. So moving swiftly along to the next case, RC is a 44-year-old woman, this time with recurrent TB lymphadenopathy, and again in the context of relapsed AML. Regarding her AML history, that was diagnosed some 6 years ago, where she underwent HIDAC and then went to allograft in 2018, which thankfully was a fairly uncomplicated post-transplant course. It was last year, however, she ended up presenting with pancytopenia, and then on repeat bone marrow was found again to have relapse of AML. And then she quite promptly proceeded to Flavida reinduction with an early repeat bone marrow that showed some persisting AML with 9% blasts. In terms of her other medical history, she was known to have had TB lymphadenopathy after her first allograft back in July of 2018. And this is of a left cervical lymph node, which again was culture positive, PCR positive, and no rifampicin mutations noted, and was treated with standard short course HRZE with excellent compliance and no intolerance during that time, with complete resolution of her symptoms. She's also had some chemotherapy-related consequences as well. In terms of her social history, it's a little bit lighter. We do know she's originally from Bangladesh and currently lives in the outer suburbs of Melbourne with her husband and 2 young children, again, all of whom are in good health. and she works in predominantly administrative work without any sort of clear TB contacts of late. Regarding her timeline, it was in June of last year that she was seen as an outpatient with this new swelling at the site of a previous known lymphadenopathy, and quite promptly proceeded to an ultrasound that confirmed an atypical looking lymph node with evidence of fluid-filled centre, with increasing pain and size noted on subsequent review. It was at this point an ultrasound-guided aspirate was performed, which in the days that followed flagged positive for TB on PCR, again, RPOB wild type. She was referred quite quickly to the TB clinic, again, confirming the history of this fairly rapid progression of her lymphadenopathy with a very fluctuant mass rather than something more solid, and no other systemic features to suggest disseminated nor pulmonary TB. And again, you've seen the image already, but at the time that she was seen in clinic, a lot of that discharge had actually subsided, and so the mass itself had flattened. And rather coincidentally, she'd had a CT chest done around that same time, which didn't demonstrate any new pulmonary TB lesions. So again, in terms of her timeline, she was then promptly commenced on HIZM, I should mention, sorry, not ethambutol. But in the subsequent haematology reviews, again, decided that she would need venetoclax and cytidine to see her through for her AML treatment, given that she had a suboptimal response to her initial induction. And again, noting the interactions between rifamycins and venetoclax, a 2-week washout period was required, and so her rifabutin was withheld for a fortnight, and she was started on her venetoclax-based therapy without significant complication. And then it was in the following week or so that the rifabutin was recommenced. Around this time, there's ongoing discussion again between the bone marrow team and the infectious diseases team, reviewing her now more finalised lymph node fluid results, seeing that she's TB PCR positive but at low levels, smear negative and culture negative after 8 weeks. And the impression at that time was that it would actually be reasonable to cease her TB therapy with close clinical monitoring and to proceed with low-dose conditioning, omitting her thymoglobulin and pursuing cyclosporin and methotrexate for GVHD prophylaxis. And from an ID perspective in particular, with her being culture negative, it was thought that her results may suggest residual antigen provoking this response, especially in the context of a relapsed malignancy. And whilst it is possible that she has culture negative infection, we know that the sampling was perhaps not as optimal as it could be, taking fluid rather than the lymph node tissue, though again, fairly unlikely, and to certainly monitor very closely for RS-like symptoms. So again, in terms of progress, she ends up stopping all of her TB therapy following this MDT. At this point, she's had about 7 weeks of treatment. And she proceeds shortly after that to her allograft, again with not unexpected complications with sort of non-neutropenic fevers actually in her case. And she was discharged home fairly uneventfully after 21 days in hospital. At her subsequent follow-up bone marrow biopsies, she's thankfully found to be in complete remission at day 100. Has her cyclosporin weaned and ceased altogether at the end of last year, with a slight complication of some concerning GVHD-like symptoms that prompted reinitiation of immunosuppression, but a reassuring gastroscopy, particularly with some of her GORD-like symptoms. And again, enduring complete remission on her most recent bone marrow biopsy. So again, a summary of her current medications. She's actually not on any of her TB medications as it stands. She's on a few prophylactic antimicrobials as expected, and she's on weaning doses of her immunosuppressants. And clinically, she still continues to progress well after her allograft, and thankfully hasn't had any evidence of TB reactivation to date. So a brief summary, a bit of a whirlwind tour of 2 patients who somewhat different presentations, although similar dilemmas in terms of balancing those medications, and thankfully both with sort of positive clinical outcomes currently. And I guess just briefly touching on sort of similar experiences in the literature, it's really, this probably one notable case of a patient who had disseminated TB. This was in Austria, who had a concurrent diagnosis of both AML and TB, commenced on HRZE, similar to our patients, and requiring venetoclax and azacitidine, just in the context of being a little bit complicated from a small bowel perforation. And this was a brief summary of the shortened venetoclax regimen that they initiated, which thankfully resulted in good responses both from an AML treatment perspective, as well as regression of the TB on that HRZD regimen. All right, I'll wrap it up there and pass it swiftly on to Ryan. Thanks very much.
Thanks, Alice.
Let me stop the screen share.
Seeing my screen now.
Yep, I just have a question from Andrew, who's one of the primary consultants of the patients. Andrew.
Oh, thanks. I'm just asking because I've got to go to clinic in about 5
okay,
minutes.
no.
But what is the frequency of TB drug resistance in these patient populations? I guess I'm just thinking we don't do a lot of preemptive therapy, so we wait until they have problems, we diagnose or culture it, and then we treat. But the risk from our point of view is the treatment doesn't work if there's drug resistance. I just want to understand how frequent that was with the drugs we're using because of venetoclax and having to amend from the traditional right therapy.
Great question. Not very high, but I'll see if Karsha's on the line who can comment.
I'm online. Justin might have more accurate numbers. I would have agreed uncommon, so less than 5%. Probably closer to 1 or 2. Justin, are you still there? Do you have the numbers?
Yeah, no, I am, and yeah, no, you're absolutely right, of course, Karsha. I mean, so our rates overall run between 1% and 2%. I guess the other thing, Andrew, is that our diagnostic algorithm is focused on early identification of resistance, and so the molecular tests that have been gestured to, but others may come back to later, are sort of specifically focused on identifying at least rifampicin resistance, but other first-line drug resistance at the time of initial diagnosis. So in terms of unrecognized multi-drug resistance at the time of starting therapy, it's really going to be restricted to those who don't have a confirmed diagnosis, so much lower than that again.
And just to confirm, the 1% is including countries that these patients might be coming from, not just Australia.
Yeah, that's right. So
85%
plus of our TB cohort overall is migration associated. So yeah, no, this is going to be just reflective of the general TB risk population in Australia.
Thanks.
Thank you. I'll hand it over to Ryan, and not to put you under pressure, but we might need to hustle. Thank you.
No worries. Thank you, Ryan, registrar from across the road. Nicola has presented, one of my colleagues presented this case previously, so I will race through the initial parts and we'll get to the update. This was my attempt to try and understand the timeline of this case, just to say it's been a very difficult time for this young man, but I will synthesize as best as possible. His early progress was this gentleman presented at the start of February. His background is he's previously well from India, and had hyperleukocytosis at the time of presentation with white cells of 570, confirming BLL on his blood film. Briefly intubated initially, had large bilateral effusions which were drained, however did not grow TB at that point. His initial BLL treatment was initiated shortly after, with the mainstay being imatinib and hyper-CVAD from the 9th of February. He had an immunosuppression screen done, which was quantiferon gold positive. His first fevers began a week after presentation, and relatively early on, it appears that there was a question of active TB raised. He was briefly isolated, but had smear negative sputum samples and TB PCR negative samples as well. The team was relatively sort of comfortable that an alternative source was found with a candida grown on blood cultures on the 18th of Feb, and he had a course of caspofungin for that with resolution and clinical improvement. However, about on the 26th of February, so now about 3 weeks into his admission, he had another deterioration with tachycardia, tachypnea, and a recurrence of fevers as well. At this point, also reporting diarrhea and a dry cough, though also had giardia in a stool sample at this time as well. A repeat CT chest was performed at this point that did show increasing worsening changes within the parenchyma, as well as some mediastinal lymphadenopathy as well. To cover for a fungal infection, treatment dose proconazole was added as well. He proceeded to a bronchoscopy on the 1st of March with normal endobronchial findings, and an LP at this time also showed leukemic spread, which he's been having intrathecal methotrexate for. So the results from the bronch were next. Again, this did not culture TB or grow TB, no PCR negative TB at this point as well, though he did have subsequently galactomannan and aspergillus positive results, which have subsequently been treated. However, his fevers continued, so given the high epidemiological risk, the suspicious imaging, and his poor response to any other treatment provided up to this point, the decision was to start TB treatment empirically, and he was started on an HMZE regimen. His initial empiric TB treatment was poorly tolerated with nausea and vomiting, so the decision was made for staggered reintroduction. He started with moxi and ethambutol only. However, a few days in, his clinical status as well as his LFTs deteriorated rapidly, and he was recurrently neutropenic at this point as well, and readmitted to ICU. A couple of days later, he was started back on full TB treatment. However, with LFTs worsening further, there was a discussion with the VIDS team about how to best rationalise his hepatotoxic medication. So he was changed from isoniazid and pyrazinamide was ceased, and he was changed to amikacin, and his voriconazole was changed to ambizone to treat his aspergillus. From about a few days after this, his general picture started to improve. And given that the diagnosis had not yet been made microbiologically of TB, the plan was to actually hold his TB treatment and try to obtain some tissue. So a PET scan around this time was performed to look to see what the burden of disease and whether there was a good target for biopsy. We can see on the scan here that there is diffuse changes in the mediastinal lymph nodes, as well as in the upper abdomen as well. He had a bone marrow around this time showing morphological remission of his ALL, as well as the EBUS performed, so went back in with the bronchoscope. At this time, they did find 2 grossly enlarged lymph nodes, and specimens and washings were collected. Lo and behold, 4 days later, we get a phone call from the micro lab, and at last our suspicions have been confirmed that he has a lymph node that is TB PCR positive, although is smear negative and cultures has not yet cultured TB, but again, consistent with a diagnosis of lymph node TB. Subsequently, again, confirming our suspicions of disseminated TB, he has grown AFB in a blood culture as well. In the last week, he's been reintroduced on TB treatment, given his previous poor tolerance. We've started in a staggered way, starting with moxifloxacin and ethambutol. He was quite nauseous, but with the addition of IV dexamethasone and antiemetics is tolerating better. Third drug has been amikacin, which has been running for a few days now. Isoniazid will follow shortly, and he's tolerating better. There's been a big focus, we've been monitoring his LFTs closely at this time. To summarise this, these are his cholestatic enzymes that tend to track better than his transaminases in his case. Just to highlight here that things were that with the initial treatment, his LFTs were acutely deranged, then improved, and have stayed relatively stable from about the 19th of March since we've restarted on TB therapy, although we're slightly worse today, which didn't make it onto this graph. Lots of ongoing challenges after a very, very awful admission for this gentleman. He's significantly malnourished, deconditioned, and other issues as well. So I hope I managed to keep that to time. And there is another case that we've also had subsequently, but I may leave that if we're short on time, but open to your thoughts.
Thanks, Ryan. I think in the interest of time and to give our other speakers courtesy of their time, we'll just move on. But yeah, definitely doesn't follow the rule book in that last case. And so what we'll do is we'll go through the final talks and hopefully have a MDM discussion with the experts on this. So I'm pleased to now introduce Eddie Cliff, who's our current haematology registrar, and I've asked him to provide and to educate us on Venetoclax. And probably one of the things that in the first couple of cases there was a real need to have both a very, very effective regimens for the AML as well as very effective regimens for the TB. So this will hopefully enlighten us on some of the issues with Venetoclax. Thanks, Eddie. We can see your slides, but you're still on mute.
Yes, it wouldn't let me unmute with the full screen. So hopefully now, can you still see them now or not?
Put it up.
See the slides now? Are they gone?
Not yet.
I'll try again. Had the slides and no audio. Now audio but no slides.
Yeah,
Have we
slides.
got both now?
Yep, good to go. Thanks, Eddie.
Okay, good. So a brief introduction to Venetoclax is essentially numerous hematologic malignancies survive in part because they're able to turn off apoptosis. And so Venetoclax's key mechanism of action is that it restores apoptosis through the inhibition of BCL2. And it does that by mimicking BH3. And so as you can see, it fits into the groove and of BCL2, and that this is what returns the normal apoptosis. Interestingly, its predecessor, Venetoclax, works on both BCL2 and BCL-XL, but this caused significant thrombocytopenia. And so as Venetoclax was developed, which many of you know occurred in large part at WeHi and by some of the leaders in the departments in the precinct, they re-engineered it to be more selective of BCL2 to try and avoid the thrombocytopenia, and it was known as ABT199 in its early clinical trials. And so nowadays, Venetoclax has quite widespread indications across hematologic malignancies, most prominently in chronic lymphocytic leukemia, CLL, where it is often used in either the upfront or the relapse setting in combination typically with an anti-CD20 monoclonal antibody such as obinutuzumab or rituximab. And an important part from particularly the CLL and the early trials is that there were a couple of patients in early trials who died from tumor lysis syndrome. And so the way that Venetoclax is now given is with a ramp up to try to reduce the risk of TLS, but and among other prophylaxis to try and reduce and prevent tumor lysis syndrome. It's also used less commonly, but in some circumstances in diseases like mantle cell lymphoma, myeloma, particularly in patients with translocation 11-14, myelodysplastic syndromes with very promising results, again led by Professor Way among other local clinicians, and the Verona trial is the confirmatory study there. And of course, the other main indication in addition to CLL is in acute myeloid leukemia, both in unfit patients for upfront treatment, particularly as shown in the VIALE-A trial, which I'll go through in a bit more detail, but also in relapse refractory setting in patients with MRD emergence, the study underway locally at the moment is called the INTERCEPT study, and or for patients who have disease that's likely to be insensitive to chemotherapy. So patients with, for example, TP53 mutations are another setting in which we would often consider using Venetoclax. And then in the AML setting, it's typically given in combination with either azacitidine, a hypomethylating agent, or low-dose cytarabine, Ara-C. And so the VIALE, I wouldn't be a hematology registrar if I didn't show you a Kaplan-Meier curve. So here's the Kaplan-Meier curve from the VIALE-A trial, which was a randomized controlled trial of the upfront use of azacitidine plus or minus venetoclax in elderly or unfit patients, 431 of them, who have untreated AML. And you'll see that the median overall survival was improved from 9.6 months to 14.7 months, so quite a substantial improvement in overall survival, with improvements also in the response rates and complete response rates. Importantly, thinking about the toxicity, this is comparing AZA to AZA plus VEN. So the comparator group throughout this slide is the AZA group. And so you'll see it does increase the nausea, thrombocytopenia a little bit, but importantly, it increases the neutropenia substantially and the rates of febrile neutropenia from 19% to 42%. So as has been seen consistently without a number of clinical trials run in the precinct, venetoclax, when it's added to any regimen in AML, does increase the duration and depth of neutropenia. And so we try to optimize the venetoclax duration depending on the patient fitness. And we use anywhere from 7 through 21 days through 28 days, with probably the most common being 14 or 21 days. So that is one tool that we do have to try and modulate that risk. And very importantly for this audience in the VLAA study, infections of any grade were increased from about 67% to 84%. Severe infections from 51 to 64%, and you'll note that only tumor lysis syndrome is quite uncommon compared to the CLL trials. We haven't talked much about fungal infections, but really the reason I mention this is because to foreshadow Emily's talk, where we're going to talk a bit about the interactions between posaconazole and CYP3A4 inhibitors and venetoclax, and to say that if I move on to this slide, there's some certainly some important pharmacokinetic data that suggests that when we add posaconazole into the picture, which as everyone will know is very important antifungal in patients with AML, that substantially increases the concentration of the venetoclax. So as you'll see in the first line of this slide, if you compare 400 milligrams of venetoclax with 50 milligrams given with posaconazole, that increases the concentration by 61%. When it's given with 100 milligrams of venetoclax, that increases the concentration by 86%. So this is important both when we think about the dosing of venetoclax and also the toxicity, particularly the neutropenia, as I mentioned. So as I mentioned in the third point here, when we adjust for the dosing, posaconazole is estimated to increase the area under the curve for the venetoclax by about 8.8 times. And so we generally reduce the dose by 75%. So in fact, usually more than that. In fact, we go usually from 400 down to 50 milligrams in terms of our local practice. And so this also presents some challenges with many of the ongoing clinical trials. And I thought one of the discussions we've had both with the case Ryan presented and our other case, which is another patient with AML and concomitant TB, is around the use of rifampicin and the challenges when we already have posaconazole interactions and the near impossibility of then adding the rifampicin and how that complicates things. And so I think I was asked to keep to 10 minutes, so I think I've kept it nice and brief, but certainly happy to elaborate if anyone has any questions.
Thank you so much, Eddie. That was a really wonderful overview. And now nicely segues onto Emily Harding's talk. Thank you, Emily, for being our pharm expert in this area. And take it away. Thanks.
There's already a question for you in the chat to get you going, Emily.
Sorry, I can't see the questions yet.
We might. It's about venetoclax levels, but why don't we?
We will have a better discussion about that.
All right. Well, why don't we get you to give your talk? And there are lots of good questions that we can all get to.
Can everyone see my slides okay?
Can see your slides. Do you want to get wonderful and we can hear you?
Perfect. So, sorry, am I in presenter mode?
Not yet. Do you want to give? Yep.
Yep,
Good.
perfect. Okay. So yeah, I'm just going to sort of very briefly try and cover some of the drug interactions that we need to consider in regards to venetoclax. So venetoclax is predominantly metabolized by the cytochrome P450 CYP3A4 enzyme. However, it is also a P-glycoprotein substrate. A dose reduction of venetoclax is required if it's being co-administered with a moderate or strong CYP3A4 inhibitors. I've just listed here some of the sort of particularly from an ID perspective, CYP3A4 inhibitors that we may have an interest in. So they do include some of the macrolide antibiotics, azole antifungals, and some antiviral agents. And I guess also of note is that many of the CYP3A4 inhibitors are also P-glycoprotein inhibitors. So most of the studies that I'm presenting today will sort of focus on CYP3A4, but sometimes it is hard to differentiate between what impact the P-glycoprotein inhibition may also have. Sort of similar to what Eddie has already presented. So in a study of AML patients, it was found that when compared with a venetoclax dose of 400 milligrams that was administered alone, if there was co-administration of venetoclax at 50 milligram dose with multiple doses of posaconazole, it did result in an increase in the Cmax by 53% and the AUC of 76% respectively. When we co-administer a venetoclax at a 100 milligram dose with posaconazole, it resulted in an increased mean venetoclax concentration by 93% and AUC by 155%. And when this is adjusted for different doses and non-linearity, posaconazole is estimated to increase Cmax and AUC by between 7.1 and 8.8 fold respectively, so quite significant. As a result, there are recommendations for dose adjustments. So this screenshot is just from the Australian product information. So Eddie did mention in AML, we do a ramp up to minimise risk of tumour lysis. So if we're going to be using it in combination with a moderate CYP3A4, we would expect at least a 50% dose reduction. If it's going to be used with a strong CYP3A4, at least a 75% dose reduction is required for venetoclax. Now, the target dose of venetoclax does vary depending on if it's being used in combination with azacitidine or LDAC or as monotherapy. So our Australian PI would suggest sort of for AML in combination with azacitidine, the dose is reduced to 100 milligrams or less, with the target dose usually being 400 milligrams. US product information has a recommendation for 70 milligrams. So in Australia, we don't have sort of readily access to either a 70 milligram tablet or a 10 milligram tablet. So we basically have access for ongoing doses of either 50 milligrams or 100 milligrams. There are also other references that would suggest using a dose of 50 milligrams, reduced from sort of a target dose of 400 milligrams if it wasn't being used in combination with a CYP3A4 strong inhibitor. We also need to consider the duration of the CYP inhibitory effect. So the product information does recommend that venetoclax dose that was used prior to initiating a CYP3A4 inhibitor can be resumed 2 to 3 days after discontinuation of the inhibitor. However, the duration of the inhibitory effect could potentially be longer. There is a study reported with the interaction between strong CYP3A4 inhibitor clarithromycin and statins. And when taking into account the half-life of clarithromycin and also the active metabolite of clarithromycin, recovery of more than 75% of basal CYP3A4 enzyme activity would be expected only after about 14 days. This is also taking into account the turnover of CYP3A4. And so that's something that we do need to consider with we do have sometimes patients who present with a new diagnosis of AML who've had, we did have a recent patient who had a recent therapy for H. pylori commenced by their GP just prior to admission. We also need to think about if there's additive effect of more than one CYP3A4 inhibitor. So we might have a patient who's requiring posaconazole prophylaxis and then has a COVID diagnosis and is commenced on Paxlovid. There has been a PK study that reported that combining a strong CYP3A4 inhibitor with another competitive CYP3A4 inhibitor did not result in any additional increase in venetoclax exposure beyond that expected with just a single strong CYP3A4 inhibitor. So at the moment, we do know that the combination of posaconazole plus venetoclax will result in an increased venetoclax exposure. But what would happen if we then need to add in TB treatment? The management of, I guess, the interaction with posaconazole and venetoclax is already complex, and then we're adding in a CYP3A4 inducer, such as rifabutin or rifampicin. A study that did investigate the impact of rifampicin on the pharmacokinetics of venetoclax, and rifampicin has been shown to have acute inhibitory effects on P-glycoprotein, which does occur almost immediately after a single dose of rifampicin. The CYP3A4 inductive effects of rifampicin generally occurs after multiple doses, as it does require time for changes in protein levels to take place. So when we compare venetoclax alone versus co-administration with a single dose of rifampicin, due to the P-glycoprotein inhibition, we do see increased venetoclax Cmax by 106% and AUC by 78%. If though it was to be co-administered with multiple doses of rifampicin, due to the CYP3A4 induction, it does result in a decrease venetoclax Cmax by about 42% and AUC by 71%. So we then sort of think about rifampicin plus venetoclax has been demonstrated to reduce the concentration and exposure of venetoclax. We do have sort of evidence that azole antifungals and rifampicin does result in reduced activity of the azole antifungals, and this is through a number of different mechanisms: CYP3A4, voriconazole, CYP2C19, and also some P-glycoprotein induction. And this is an example of a patient who, a newly diagnosed AML patient who had chemotherapy with us last year, was commenced on posaconazole prophylaxis 17th of August. And we do have 2 therapeutic posaconazole levels that were achieved with prophylactic dosing. And then commenced treatment for TB with rifampicin. Rifampicin was commenced on the 23rd of September. And then you can see the significant subtherapeutic posaconazole level, despite sort of achieving therapeutic posaconazole levels prior to commencing the rifampicin. So the combination of rifampicin plus posaconazole leads to a reduced concentration of posaconazole. What then happens if we were to combine all three? So a strong CYP3A4 inhibitor, such as posaconazole and another strong azole antifungal, together with venetoclax, together with rifampicin, which is a strong CYP3A4 inducer. And I don't know what to do. I guess potential management options that we'll probably discuss is it appropriate not to use any antifungal prophylaxis in these patients? And it might depend on the stage of the patient's treatment, whether or not it's a newly relapsed AML versus a patient who has got stable blood counts. Do we consider an alternative non-azole-based fungal prophylaxis? So AmBisome, which is IV dosing, inconvenient for patients and costly. What is access to therapeutic drug monitoring? So even in our example at Royal Melbourne, we can only do sort of posaconazole drug levels once a week. So if we are planning to sort of monitor the impact of rifampicin and interaction with posaconazole, we're going to be chasing our tails with just once weekly levels being available. And there's no readily available monitoring assay for venetoclax drug levels. Do we need to consider an alternative non-rifampicin-based TB regime? But then we also need to think about what are the risks of QT prolongation, particularly with moxifloxacin and azole antifungals plus ondansetron plus sort of multiple other drugs that these patients will likely be on. I think that's everything.
Thank you so much, Emily. I wonder if you can just put it back to the previous slides, because they really sort of summarise some of these issues. And thank you so much for explaining so simply all these complications and additional things. And agree, it's a evidence-free zone, or all the combinations at once. I wonder, please put your hand up for any questions. And I did, Joe.
Thanks, Michelle. I think I was on service when some of this was going on with the venetoclax and the rifampicin issue. One of the issues that cropped up is there was a delay in trying to make a decision about what TB therapy was to be used. And there was an urgency about starting venetoclax. The patient needed to do it quickly, and there was also a 2-week washout we had to wait for. So there was an element of time here. So my point is, I think we need a unified position about what we're going to use in terms of TB therapy going forward, so there is no further delay. Do we use Moxi, or, I mean, the other drug that was mooted was bedaquiline, but of course we can't get access to that. So really, I think we're left with Moxi, but I think we need a unified approach. And the second issue around that is, where are these patients followed up? Because they tend to be lost if they sort of flip between Peter Mac and the TB clinic. So I think we need a decision and maybe even a triaging system of whether they go to TB clinic or stay at Peter Mac. And my feeling would be, if they're really complicated, maybe they go to TB clinic. If they're straightforward, they stay at Peter Mac. But that's open for discussion.
Thanks for that comment, Joe. And I might invite Justin to comment briefly, but also to comment just as you've written about the differences between using a rifampicin-based regimen versus a rifabutin-based regimen, and Emily's point, which from your opinion about a non-rifampicin-based TB regimens. Thanks, Justin.
It's a dangerous thing to invite me to comment
Yeah.
briefly on, Michelle. I mean,
It
maybe
is.
just a couple of things. Can I start with VPOM? Because I've, it's been mentioned a couple of times, and people have talked about difficulties in accessing this. So I just want to clarify that. First is we can get access to these medications. We do use them. They're routinely used now as first-line therapy for multi-drug resistant TB, but we are open to considering them in situations where it's appropriate for non-TB. And typically, what we're looking at is for people who've experienced severe treatment-limiting side effects. But we're open to a conversation. There are some reasons why BPOM I don't think is an ideal regimen for this group of people, and we've touched on a few of them today. 6 months of linezolid, a bedaquiline with a half-life of 9 to 10 months, QT prolonging drugs for moxi, bedaquiline particularly, but also the fact that there's no non-oral formulation of several of these drugs. And so for people who do need IV therapy, then they're not ideal for having to bridge between that around mucositis and other reasons why people aren't tolerating them. So they're available, we can consider them, but there are some reasons why I think they're probably not good first-line drugs to be routinely used in this situation. As far as the clinical follow-up issue, yeah, I agree. We all want these people to be managed well, and we do all see from both sides of Grattan Street, I think, some issues that get lost back and forth. And there are complicated hematologic issues being managed as well as complicated TB. So I think probably the really key thing is that we want to have good communication. So very happy, regardless of where they're being managed, to have direct phone conversations, multidisciplinary meetings, making sure that we understand the nuances of what's happening on either side of the fence is kind of where I'd start. But happy to talk about any more specific details that are useful.
So Justin, can I just follow up on that, given that we're not likely to use a bedaquiline containing regimen? So is moxi the appropriate way to go and just not use rifampicin or rifabutin? I think we just need a way forward on this to avoid delays.
Yeah, so look, that's perfectly reasonable. I mean, if you've got or strongly suspect a drug-sensitive TB, substituting rifampicin for moxifloxacin will give you, sufficient agents. It is not as good in the sense that we know that giving standard short course therapy where you use moxi instead of rifampicin, there's higher treatment failure rates, is not what we recommend routinely, but that can be extended out to 12 months to give an effective course of therapy. So, initially getting started, that can be fine. That does bring me back to the question that I asked in the chat, though, which is that, we think of rifabutin as being less problematic in terms of drug interactions, but find it hard to pin down exactly how much we should prioritize that for venetoclax, because for me, in a particular situation, I would prefer to start with a rifabutin, to a rifamycin-based regimen if possible. So if we're comfortable that there's a way to use venetoclax with rifabutin, that's what I'd suggest is first-line therapy. If we're not, then yes, probably initial bridging therapy with moxifloxacin is the most reasonable interim arrangement that we've got for rapid starting care.
Thanks for that comment. I want Monica. We'd love to hear your comments.
Yeah, thanks a lot. Great cases and great discussion. I think when I've asked about rifabutin in the past, there's really been a reluctance to say that it is any less, drug enzyme inducing than rifampicin. So I guess the kind of information we've got from our pharmacists is probably no advantage. And so maybe we need to relook at that. And I guess, in terms of moxifloxacin, I think that would probably be our logical choice if there's no advantage to rifabutin. And I think that we can manage the prolongation of QT, for example, if we have savuconazole potentially, and maybe that's just a decision we should make. If we're using moxifloxacin to treat these patients, maybe we should be looking at savuconazole as their standard prophylaxis, bearing in mind that there are some data that say it is less effective and there's more breakthrough rates, although that data has been challenged recently. So I think that the other point to make is maybe we should be advocating for more frequent POSA levels. We can talk to our pathology service about that also. I think that's another thing that comes out of today's meeting. So there's, and as for where the patient should be treated, I think followed up, I'm very much in agreement with what Justin says about multidisciplinary meetings, and these kind of meetings are so valuable. I think we should not focus on so much where they're followed up as on our communication.
Thanks, Monica. Looking at the chat as well, Ben has proposed feasibility or potentially using rezafungin as our prophylaxis, avoiding the azole group.
Sorry, Michelle, I was just being cheeky. I'm not. Yeah. It's not widely available, but just thinking about how if you can remove one additional hurdle, and obviously Reza is once a week as opposed to more commonly with more frequent dosing with Ambisome, that's something that you could, and it's not perfect. I mean, as Nick has, pointed out, it doesn't cover mucor, but, if you cover Aspergillus plus, all the yeast or Candida at least, that, it gives you some coverage. But anyway, it was just more for academic for
yeah,
now.
No, great. And that's wonderful. Well, it's bang on 1:30. I think this has been a wonderful meeting to get everyone on board discussing all the different issues. And I think it will be in touch across all our different sort of craft groups to come up with some sort of outline, and even as Justin has said, to look into these interactions a little bit further, as more and more people will be exposed to Venetoclax, and as we have more and more Australians born overseas or with relevant risk factors. So thank you everyone for joining us here today. Thank you.